So today, again, it's an honor for us to have with us Dr. Brenna Chalmers. And Dr. Chalmers is a graduate of UCLA undergraduate. She's a graduate of UCLA School of Medicine. She took her residency in Diagnostic Radiology at the USC School of Medicine and the LA County Hospital. And she did her residency in breast radiology diagnosis of breast disease. And she's on the staff at St. Jude Medical Center. And she's here today to talk to us about the field of diagnostic radiology in the treatment and diagnosis of cancer. So please welcome Dr. Brenna Chalmers.
Thank you. Well, thank you guys for having me here. I'm really excited to present to all of you, and thanks for choosing me over the baseball game. I had no idea. I will tell you that radiologists were not known as the most exciting and scintillating specialty, so you might have wished you picked the baseball game. But hopefully get some good information. Please feel free to ask questions, interrupt me, that's fine. I'm not quite sure how long this is. I think it's shorter than the allotted time, so please feel free to pipe in. So just quickly, cancer imaging, we use it for many different parts. We screen for cancer, diagnosis and staging of cancer, guiding ongoing cancer treatments, determining if the treatment is working, and monitoring for recurrence once the cancer has been cured. We use lots of different imaging modalities, just to name them quickly: X-ray, fluoroscopy, ultrasound, CT, MRI, PET, and nuclear medicine. I'll briefly just kind of overview those so you understand more when we go into the specifics. So X-ray, everyone's familiar with X-rays. Everyone's had a chest X-ray. The images are produced by X-rays due to different absorption rates of the different tissue. So bone, nothing can penetrate. So it can't get through to the film, so it looks white on an X-ray. That's why we often use it to look for fractures and other things. Mammograms are actually a type of X-ray, so they fall into the same category. They're just super high resolution X-rays, which is how we're able to detect really tiny cancers, look for tiny microcalcifications, and we'll go into that a little bit more. Another study is fluoroscopy, which is also a pretty common procedure, so many of you might have had a fluoroscopic procedure. It's usually called like an esophagram or an upper GI. Basically, it's also X-ray, but it's used with a video screen. So it's kind of like a movie. We can watch the body in motion. As far as cancer imaging is concerned, usually fluoroscopy may be used if a patient comes in and they're saying, I'm having a really hard time swallowing, the food's not going down quickly, and the ordering doctor wants to see, how is it moving? Make sure there's no obstructing lesion in the esophagus. That would be the one thing we're worried about. The other, not as commonly, thankfully, is we used to do a lot of barium enemas, which was another procedure to evaluate the colon and look for colon cancer. Luckily, colonoscopy and virtual colonoscopy has become more used, so barium enemas, no one has to deal with that as much anymore, which is thankfully. This is just an example of a fluoro images. So this was kind of like coned down so you could see a little bit better. And I don't have a mouse to show you, but you can see this is the esophagus, so the white is the contrast that the patient drank, and you can see how it looks like it's narrowing. That arrow is kind of pointing. It looks like it kind of has like a collar or like a beak there. So that's actually what it looks like when there is an esophageal cancer present. So it causes this narrowing. So the white is what you drink, and it can't get through that well, that narrowing. So that would be very concerning for esophageal cancer. We saw that on an esophagram for someone coming in with difficulty swallowing. Sometimes they can be a lot more subtle and be short little areas of narrowing, but that's what we're looking for. Ultrasound, also probably most of you familiar with, but ultrasound is non-radiation, so it uses sound waves, and basically ejects the sound waves into the tissue, and different tissues retract or reflect that sound at different speeds, and based on that we can pick an image. And don't make me go into the physics of that. Probably some of you are ex-engineers and can explain it better than me, but it uses the sound waves to kind of differentiate the different types of tissues. That's why we especially use it when we're looking at soft tissues. So if you are feeling a mass in your arm, the doctor may recommend an ultrasound of that area first so we can kind of really delineate the tissue. Also, we use ultrasound a lot for biopsy guidance. So it's non-radiation, so if we can do a biopsy with ultrasound, we'll use that for something that you can't necessarily feel. And then quickly, so CT is also X-ray, so it's a computer-generated X-ray. So this image on the top is, kind of like looking into the scanner of someone going through, and you can see all those beams going through. And basically, the computer will put the X-ray beams at multiple different angles as the patient's moving through the gantry. And that allows us to see a three-dimensional image. It used to be, now we do spiral scanning. It used to be that it was more, you would take an image at the one place and then the patient would move, and then you would take images of that. Now it actually goes around in a circle, so it's a continuous. So we get higher resolution. The images are beautiful now. These are two images of a CT chest. So this is the heart here. This study is a non-contrast study. So the benefit of CT is we can give what's called intravenous contrast, which is the difference between these two images. So this is after the injection of intravenous contrast. You can see this is the aorta here, the heart again. You can see the contrast flowing. And so why that's important with cancer imaging is that tumors have abnormal vessels that will help it form. So you'll usually see a cancer will have more vessels in the surrounding tissue, so they take up that contrast. So a lot of times ordering doctors, especially primary care physicians, their most common question is, should I order the study with contrast or without contrast? And generally, a general rule is if you're looking for cancer, if that's your concern and a patient has normal renal function, it should be done with contrast, with intravenous contrast. The other indication would be infection. So inflammatory tissue also has more vessels which supply it, which will lead it to enhance as well. So those are the two main times we want to use intravenous contrast. If a patient, and there's other, if you're looking for a vascular injury, but in cancer imaging, that's the biggest thing, is that you want contrast if you can get it. Oral contrast is when you actually drink the contrast and it kind of illuminates the bowel. That's important sometimes in pelvic cancers, so any kind of gynecological cancer, or even sometimes like a pancreatic cancer, because sometimes the bowel can overlap those areas and it makes it harder to delineate. MRI, so just to compare, so this is a CT image of the knee and this is an MRI image of the knee, and you can see there's a lot more detail in the soft tissue. So here's the muscles, here's the bone, you can see the bone marrow really well, the ligaments, quadriceps tendon, and the patellar tendon. Whereas on the CT, you can see the bony detail really well. So this is the bones, and you can see if there was a fracture. But MRI, a lot more soft tissue, three-dimensional. In cancer imaging, MRI is often used for brain cancer. That's a more very common one, sometimes liver cancer. It also helps when there's bone lesions. So sometimes there's suspicion for bony metastases and we get a CT or an X-ray, we don't see anything. But on MRI, you can really pick up subtle marrow changes. So it's very helpful in those cases when we're unsure. And then molecular nuclear imaging is a whole other world within radiology itself. It uses low doses of radioactive substances linked to compounds that the body normally uses. So the most common one in cancer imaging is called PET scan. And basically, it's just putting something radioactive on a sugar molecule to make it really simple. And that's what we're doing. So the technologist injects this compound, and then you wait 60 minutes and you wait to see what parts of your body take up that glucose. So what takes up glucose the most? Your brain. Your brain takes up the most glucose. So on a PET CT, you can see the brain light up, and I'll probably have an image of that. But it would not be good for brain cancer because you wouldn't be able to tell what's abnormal or normal because the whole brain takes up the glucose. But it is really good for other cancers, including lung cancer. Lung cancer will use more glucose than the normal tissue, so you'll see it light up. It's like the easiest thing for a radiologist to read. It's a complicated study, but as far as reading it, it's very simple. So here's some images from a PET. So the actual PET images are just these ones here. So they're really grainy, ugly pictures. That's why we always combine it with actually a CT. Usually, most places will combine. At St. Jude, we always combine with a CT, and we get what's called a PET-CT fusion image here. So in this case, this is a patient with colon cancer. As far as defining colon cancers on CT, it can be very difficult. So it's this little area. This is the little cancer here. You probably would never call this on a CT without the PET image. That's because the colon's always moving, so it's normal to see areas of thickening within the wall. But with the PET, we can say, there's this area that's taking up much more activity than any of the remaining colon. So that's definitely abnormal. So this would be, we would say in our report, this is very suspicious for colon cancer, recommend a colonoscopy. So you could go in and biopsy it. One other thing, if you ever hear about a PET scan that you may hear radiologists talk about, is what's called an SUV value here. And basically, that's just a great fancy grading system. So does it take up more? It has a higher SUV value, or if it takes up less, there's a lower SUV value. So that's particularly important with lung nodules. Sometimes it's hard to discriminate if it's a benign or malignant nodule, so we use the SUV values with different cutoffs to help us determine. Another common imaging modality used with cancer is what's called a bone scan. So again, just like the PET scan was sugar connected to the radioactive substance, this is MGP, which is like diphosphate. So something that the bone normally uses attached to a different radioactive substance. So this is technetium-99m. And basically, whenever bone is turning over, it will take up this MTB. So this is kind of what a normal person, normal bone scan would look like. So you see normal uptake in the kidney, these are the kidneys, you see some uptake through the spine, and then you can see degenerative uptake. So if you have osteoarthritis and you get a bone scan, you're gonna see uptake there because the bone's remodeling with the wear and tear. But generally, if it's symmetric like this, we're not worried that there's cancer in your knee. This is when we'd be more worried. So this is widely metastatic disease. So we see abnormal areas of uptake throughout the skeleton. And usually when someone's going under cancer treatment, they may start with an initial bone scan and then they'll get follow-up bone scans to really evaluate for change. This is especially important because sometimes a bone lesion will stay abnormal looking on a CT or an MRI. It'll always look ugly. And the only way to tell if it's actually still cancer or if it's been a cured cancer is sometimes to get a bone scan to see. Because if there's no uptake there anymore, it's just dead bone. That cancer lost. It's not, it's not taking any of the new material up. Just briefly, radiation risk that always comes up because a lot of these studies that we talked about do use radiation. So the American College of Radiology had a task force, as well as the Radiology Society of North America, to make sure that we're not only using the techniques that we're using the best technique to lower the radiation dose, but also eliminating unnecessary procedures. So if any of you guys get care at St. Jude and go through the ER or inpatient, your doctors might be griping a little bit because they just instituted where the doctor has to make sure the code matches up to what they're ordering exactly as approved by the committee. So that's kind of a game. So if the computer doesn't think that's an appropriate indication for a study, it won't let the doctor order it. So they're kind of learning how to use that whole system. Image gently is just in relation to pediatric patients, really making sure those protocols are specialized for them. So just going into some specific cancers, and you guys are going to be at an advantage when you go to the lung cancer and prostate cancer meetings, because I touched on that a little bit in this presentation. I'll start with my specialty, which is breast cancer, a topic that most people are familiar with, especially since it's October and it's Breast Cancer Awareness Month. But briefly, 1 in 8 women will be diagnosed with breast cancer in lifetime. Current recommendations by the American College of Radiology is annual screening starting at age 40. You're going to see all different recommendations out there, but we still believe that 40 is the right age to start, and it should be annually, not every other year. And screening should continue as long as a woman is in good health. They used to say it is expected to live 10 more years, but that's kind of fallen out of favor in the sense that if a patient's healthy, not all breast cancers will require chemotherapy or surgery. Some can be managed for a long time with hormonal therapy. So it's not something that may impact someone's quality of life that great, to get some treatment to hold a cancer. So it's really something that someone should talk to their primary care physician about to see if screening should still continue. I will tell you at St. Jude, we screen 80 and 70-year-olds routinely. I would say that's a large proportion of who we screen. By detecting cancer at earlier stage, we decrease the cost of treatment, and we also show a decrease in mortality by at least 30%. Just to show survival by stage, obviously the higher stage, the 5-year survival is lower. So stage 1 cancer has 100% 5-year overall survival, whereas a stage 4 would be 20%. Screening, as far as screening for breast cancer, we also do use ultrasound, which is becoming more and more used. So what happens is a lot of patients will come in for their screening mammogram and will also get a bilateral screening ultrasound at the same time. That's where you would go in the ultrasound, and a technologist will scan both of your breasts, the entire breast, just looking for any suspicious mass, or look at the lymph nodes as well. The reason why we don't do screening ultrasound on everyone is it's very user dependent, it's time consuming. A technologist, sometimes the exam can take 20 or 30 minutes, and we find a lot of incidental, like little cysts and masses that probably will be of no consequence to a patient, but sometimes they lead to unnecessary biopsies, more follow-up. So we really don't want to have everyone coming in for screening ultrasound. We want it to be targeted at patients that have a higher risk or patients that have dense breast tissue. And then breast MRI is also used for screening. Some people may be familiar with MRI as far as breast cancer after diagnosis, but it's actually becoming more and more used for screening. Currently, they recommend it only for patients with greater than 20% lifetime risk of breast cancer. So that is patients with BRCA1 or 2 gene mutation, patients that maybe had lymphoma when they were younger and had radiation therapy, and other genetic syndromes. But there's more and more literature showing the people that fall into this intermediate risk category, which would be the 10 to 20%, would benefit highly from screening breast MRI. Some places around the country are now doing abbreviated protocol MRIs, where it's like a 10-minute MRI, limited, quick look at the breast. We don't have that here. It's still kind of mostly at academic institutions, but it is something that we'll probably start seeing universally more. Just a touch on breast density, because I think most patients that come into the breast center have a question about it. Mammography has a relatively high sensitivity for detecting breast cancer, greater than 85%. This is traditional 2D mammography, but still misses about 15% of cancer, and those are usually patients with dense breasts. So just to give you a visual, so when you hear the density, so this is a patient's left breast. These are all different patients' left breasts. So the black on the mammogram is fat. The white on a mammogram is the fibroglandular tissue of the breast. So this patient has very dense breasts, very little fat. This patient has mostly fat. The problem is on a mammogram, cancer is going to be white. It's going to look white. So when you have tissue like this, it's very difficult to see a cancer. You're not going to see it through this dense tissue. If you have fatty tissue, it's going to jump out. Anyone could read it. You guys could read these mammograms. They're easy to read. So the real problem is these patients with heterogeneously dense and extremely dense tissue. Just to quickly go through a case of kind of detection mammogram case. Here is, see this image, it looks kind of junky next to this one. So this was before digital mammography. So this is an analog. And the tissue, you don't see this detail as well. You don't see the skin as well. You can't see the nipple. Here's the nipple here. And this is the person's current mammogram, which is a digital mammogram. So here, this patient came in for a screening mammogram, and there's this little density right here, which was new from the prior study. Screening study, so we brought the patient back in and did diagnostic workup. So diagnostic workup means additional views. Here we can see we put this paddle on the patient, we try to spread the tissue out. We see there's a persistent, about 5 millimeter density right here. So this patient went on to have ultrasound. These are the ultrasound images, and you can see this area of shadowing here, right here. This is like about a 5 millimeter mass, and that corresponded with the area we saw on mammogram. The patient had ultrasound guided biopsy. We always put a clip in when we do the biopsy, and this was a 5 millimeter stage 1 breast cancer, so very good prognosis. Now, and at St. Jude, this is how the breast surgeons operate, is most patients that have a diagnosis of breast cancer will get an MRI. And what that does is it helps us look at the other breast and also make sure we're not missing any additional disease in the same breast, so that when they go to surgery, they know exactly what extent of tissue they need to remove, or if a patient's a better candidate for mastectomy. So this patient was exactly what you want to see. Small mass on a screening mammogram, and she got the breast MRI and no other enhancement. So this is the right breast. You don't see anything light up. Here's the left breast, and there's that tiny cancer. Just to review some of the other image-guided procedures we do in breast cancer imaging, we do ultrasound biopsies, we do stereo biopsies, and we do localization. So the surgeons, anytime a patient's having a lumpectomy, or most times, the patient will come to us prior, and we will mark the area for the surgeons. Surgeons think they're all good, but they need our help. So we put these little markers in for them to mark the area that they need to be removed. This is a different patient than the last one. So we put these wires through the skin to target the area, and then this was the lumpectomy specimen that the surgeon took. So this is the tissue, you can see the mass in it and the wires that were bracketing it to make sure that they get clear margins.
Wires, that seems painful, putting wires in.
You would think it's not comfortable, but it's actually tolerated more than the actual biopsy. So the patient, if they're getting wires done, they come the day of surgery. So they'll come in the morning, and it's actually, you numb the skin just like you would numb for anything else with local anesthetic, and then you just use a small needle that is hollow inside to put the wire through. So it's actually very quick. The main reason why sometimes women will complain is that they're in compression, like a mammogram for sometimes when we do it. So they have to stay still, but it usually takes about 10 minutes. Yeah, and then you do have wires, and patients always joke, oh, I'm gonna be getting radio signals, or what's going on. But we tape it down. At USC, we actually would sometimes do these the day before, so patients would actually go home with the wires, which I think was not tolerated that great. So now they're just in the hospital. It's right before surgery. We tape it down, which is why now actually we use, I said seed localization. So seed localization gets rid of the wires, and what we do is we put either magnetic or radioactive seeds in the area. And then the surgeon in the operating room has a special device to detect those areas. So we're getting away from the wires a little bit. The good thing about the seed is that we can do it on a different day. So patients, they're already getting up early for surgery. It's a long day already. So this allows them to come in on a separate day, just get the seed placed. That way they're ready to go the day of surgery. The surgeons like that too, because they don't have to wait for us. And just briefly to touch on tomosynthesis 3D imaging, which we're really excited, thanks to some of the people in the room who helped contribute. We're finally doing it at St. Jude. So we've been doing it for about a year. We're in construction, so we will have 4 units at our center soon. Just to say, so when we talked about those dense tissue and how we couldn't see those white cancers in the white tissue, this really is a big help. This solves that problem essentially. So what tomosynthesis is the X-ray tube here, and it moves around. So here's the breast, it's in compression, and it moves around here along the breast, creating images at different projections. So then we get a 3D image of the breast. So those patients where it was dense, we can scroll through like the pages of a book. We can look through and we can see through that tissue and see those tiny cancers. It's been amazing at St. Jude. We found so many smaller cancers that we would never have seen without it. Many studies have been done on 3D. It increases detection of invasive cancers by greater than 40%. And it also reduces false positive rates. So oftentimes people get called back for a screening mammogram. Many of the women in this room have probably had that experience. And you go in and you worried for weeks until you get that appointment to come back in, and then you come back in and you find out, oh, it's great, but you still had, maybe 2 weeks of being anxious about what was going to be shown. So this reduces that. That reduces the number of people that get called back for something. Basically, we can say, oh, scroll through, oh, that's just your normal tissue, nothing to worry about, we don't need to call you back. And we're seeing that in proof in this last year that we've had it at St. Jude as well. And it also can be formed with the same low-dose radiation as a 2D mammogram, because we're using a reconstruction technique to make the 2D images. Just to show a couple cases of 3D. I can't do the movie in here great. The PowerPoint, it wasn't working well. But this is a 2D mammogram. So this patient has really dense tissue, right? So you see, like, there's like, what is this? What is this? It's all white. Who knows? We probably would call this normal on most days. Here is a cut from a 3D image. And you can see right here, this is a mass. So it's irregular. We're looking for the shape. You see all this like lines coming out from it? We call it spiculated. So it's a spiculated mass right there. In retrospect, you're like, oh, it is a little dense there. But it was also a little dense here. It was also a little dense here. You wouldn't have called it and you wouldn't have seen these spiculations without the 3D. So that's a cancer that you would not have picked up. Here's a zoomed in view of another patient. Same patient, so dense tissue, lots of little areas of white, lots and lots of white. Do the 3D image, jumps out. We see this star, this is cancer. If I biopsied this and it came back as not cancer, I would say that's not right, it needs to be removed. Classic. So it just really jumps out on those 3D images. Okay, moving on from breast, I'll talk a little bit about lung cancer. I didn't realize Dr. O, the expert, was gonna be here in a couple weeks, but I just kind of briefly go through it. Lung cancer is the #1 cancer killer in the US between male and female. It's extremely common. Most patients are diagnosed with advanced disease because they don't present with symptoms, so it's already metastasized when they come in. So you can look at stage of diagnosis from localized, regional, distant. So distant metastases, that's how many people compared to localized disease are coming in. So not too long ago, there was a national lung cancer screening trial. Large clinical trial, over 50,000 patients at risk for lung cancer. In that study, they included patients that were 55 to 74 years old who were current or former smokers. And they randomized the patients to either get what was traditionally used as screening, which was a chest x-ray, to those getting a low-dose CT scan. And they looked at the comparison of people with chest x-ray versus the CT. The people that had the CT scan had a 20% decreased risk of dying from lung cancer. So only 320 people need to be screened to prevent one lung cancer death. Seems like that's a lot, but that's one death saved from just doing lung cancer screening. This detects cancers at the earliest stage, just like screening mammography. So this was the first time the study showed that lung cancer screening decreased lung cancer deaths. Previously, they looked at chest x-rays, and I can tell you, I read lots of chest x-rays. You can miss a giant mass on a chest x-ray. I don't want to dissuade you, but it's hard to see on chest x-ray. There's poor resolution. CT can see through that tissue so much better. So the results were announced in 2010. And so now lung cancer screening, I don't know how many of you have heard about it, but it's going on across the country. We have a whole program at St. Jude, which I'm sure Dr. O will talk about, but it's underutilized. The program's been in place, and I don't think many people still know it's there or are using it. So who should get screened? So we talk about patients that are 55 to 80 years old, current or former smoker, and we define it as greater than 30 pack year smoking history. How we calculate that is the packs per day times the years smoked. So 1 pack per day for 30 years would be the same as 2 packs per day for 15 years. And you have to be asymptomatic. So these are patients that aren't having like a new cough, aren't coughing up blood, not increasing shortness of breath, just going about their life but have a history of smoking, okay? The goal of this is to detect lung cancer early when it's curable, decrease the chance of dying from lung cancer. So I don't know when the statistic was from, but they say that 7 million Americans are estimated to be eligible for lung cancer screening. But they said, and I think this was a few years old, that less than 4% have undergone screening. Dr. O will have the latest, but I can just say from experience, we don't see a lot of lung cancer screening coming through. What is a lung cancer screening study? So we said it's a CT, but it's actually a really low dose CT. We're not looking at it to look at the vessels, to look at the soft tissues, to look at the bones. We just really want to see the lungs. We find incidental things, but our main concern is to look at the lungs. So we don't use contrast, even though we're looking for cancer. We're just doing a quick CT. It's under 1 minute. And then there's 3 basic possible outcomes from a lung cancer screening. So you can have a negative screen, so we see nothing. So it's completely normal. This is pretty uncommon. A positive screen, so something that's suspicious for lung cancer that then is recommended to go for biopsy and surgical consult. Or something we see a nodule, but we don't know. It's indeterminate. And I'll show you another slide that goes about that a lot. This is where most people fall. Some of the nodules we can say are definitely benign, but some of them are indeterminate. So this is the lung RADS delineation, which is what we use to decide what's the next step. So you have a lung cancer screening, we see a nodule, what do we do? So I know it's super small, but I can barely see. We look at the size, we look at the composition of the nodule, and based on that we'll say continue annual screening, 6-month follow-up, either a shorter follow-up, so a 3-month follow-up, a PET CT possibly, and maybe a biopsy. And then these are ones we really recommend a biopsy and PET CT for, so these higher. And that's just based on size and the composition of the nodule. As far as radiologists' role in lung cancer treatment, we're doing more and more of what's called radiofrequency ablation. There's also microwave ablation. We're at St. Jude, we're just doing radiofrequency ablation. And basically, it's where we place a needle through the skin into the chest. It's a special probe that releases electrical currents into that area of the mass and creates heat, killing the tumor. So this is really effective treatment for patients who are not good surgical candidates, have comorbid conditions, cannot undergo a major surgery, or for patients maybe that have multiple metastases and some are responding to chemo and some aren't. So then we can target those ones. It reduces the size of tumor. Another indication is it can cause pain relief. So it's kind of like a palliative treatment. Just by treating them, the tumor decreases in size. The patient can breathe a little bit better, not cause as much discomfort. This is just an example of what a lung cancer screening looks like with the mass. So this is the CTs we looked at earlier. You remember we could see the bones really well. This is windowed, so we just see the lungs. So this is lung here, this is lung here. And these little dots are the little vessels supplying the lungs. And here's this mass. So it's in the right lung. It's just like breast. So it's spiculated, irregular. So that's concerning for a lung cancer. So this is one that was recommended probably for Dr. O consultation for removal. And then these are just some pictures from a radiofrequency ablation. So this is the patient's skin here. This is the tumor. And this is the needle with the probe coming into the tumor here. You can see it opens up, so it really gets into that mass here. These are subsequent slices. And then you can see this is actually post-treatment, so you can say, wait, it got larger. Why does it look bigger? That's actually exactly what you want to see. That's a good response. So the whole area was treated. You see this like kind of puffy area around it. That's the tissue around it reacting too. So that's a good response. And these patients will go on to be monitored after the treatment to see how it looks. Moving on then to prostate cancer. So the main thing that radiology has a paradigm with prostate cancer is MRI. We're doing more and more MRIs of the prostate gland. It's not a comfortable study for men. We were talking about the wires in the breast. Prostate MRI uses an endorectal coil. So it's not the most comfortable exam, but it is a very good study to look at the prostate gland. So initially, it was used exclusively for men with known prostate cancer. So prior to having surgery, radiation therapy to evaluate extent of disease. We're finding newer indications for using it. So those other indications are, say a patient has a really elevated PSA, they go into the urologist. The urologists kind of do what's called like a blind biopsy. They just biopsy around. They're not looking, they're just biopsying areas in the prostate gland. So say they do that and it comes back negative, but you have a really high PSA. What's causing that? So then they may have you come get a prostate MRI. And what that'll do is help us target, oh, that's the area that's abnormal. Let's make sure we sample that, which is what we have started doing. I'll show you a picture of that, which is we're doing MRI-guided biopsies. It's also used in patients that are going treatment or being monitored for prostate cancer to look for a response. Is everyone too bored yet? Are you okay? Keep going. Just like the breast cancer and also like the lung cancer, we do risk stratification based on the imaging. So from 1 to 5, how likely something on a prostate MRI is cancer. These are just some images from a prostate MRI. They're kind of grainy images, but they actually have a lot of information. So just to orient you, this is the prostate gland. These are the seminal vesicles here. So these are different sequences that we did, same prostate gland, but just different sequences. So this area here, can you see how this area is a little darker? Then this is a normal gland, this area is darker. On this image, you can see it looks a little bit brighter. Here it looks, that same area doesn't look like the rest of the gland, it's a little darker. Here's after contrast, and we can see it lights up. So this would be a very suspicious lesion, and it's actually invading into the seminal vesicle, so it's a more advanced prostate cancer. So images are kind of grainy, but they have a lot of information. So this is prostate fusion biopsy, which we're now offering at St. Jude's. We just started doing. So this is an image from the MRI. It looks pretty. Radiologists like to add color to make things look prettier. But this would be the area that was abnormal. And then it's fused through a program with an ultrasound, so that then the radiologist can go in and do a targeted biopsy of that area, as opposed to what the urologist does currently. So they fuse this so that we can see on the ultrasound, and then we'll use ultrasound guidance during the biopsy. So it's just a great way to make sure we're getting the most suspicious part of the prostate gland when we're sampling. Okay, so liver cancer. Moving on. So hepatocellular cancer is the 4th most common cancer in the world, much more common in men. I've seen it in patients with hepatitis B, hepatitis C, liver cirrhosis, and now we're seeing it some in patients with none of those risk factors but have non-alcoholic fatty liver disease that has gone on to be advanced, can also develop liver cancer. As far as screening, the GI doctors use what's called serum alpha-fetoprotein, which is a lab test. If it's elevated, they can be more worried for liver cancer, but it's pretty nonspecific. So patients that are at really high risk, they'll recommend ultrasound every 6 months to monitor the gland. This is where radiology has a lot of options as far as the treatment. And I don't do these treatments, but several of my colleagues do, the interventional radiologists. And we do what's called chemoembolization, ablation therapy, and radioembolization of liver tumors. Okay, so the first one I wanted to talk about is transarterial chemoembolization. This has been getting done for a while, but more and more. Basically, let me orient you to this picture because it looks like a spider, but this is from an interventional, so like a cath lab. If you've ever had a coronary cath, this is how the images look when they're doing it. This is the radiologist's catheter, and what it's doing is going into the hepatic artery here. So see how this all like kind of lights up. We talked about why we give contrast for tumors and CT and other imaging. They have all these abnormal vessels. So this is like a normal vessel, nice and smooth. These ones look like spider webs. That's what tumors do. They develop these weird vessels. So the radiologist puts this in, injects it, and they can see that all these abnormal vessels are right in this area. That's where the tumor is. So basically what they can do is through this catheter, inject the chemo directly into the mass. So as opposed to doing necessarily systemic chemotherapy, they inject it right into the area of concern. So they get into the small little vessel. At the same time, they'll do embolization of the surrounding blood vessels so that the chemo doesn't go into the other parts of the liver. So this is post. So here he's still injecting that same area, and you can see there's no enhancement of that area anymore. All those vessels supplying that tumor were killed. So that'll treat the cancer right there. Here is another example. So this is a good example of what a liver tumor would look like on CT. So this is a contrast study because we see the aorta here is nice and bright. We can see this mass here in the liver. So this is liver, spleen, just to orient you. You see this enhancing mass. Here is what it looked like originally on the angio images. So you see all these spider web vessels, very similar to the other one, so abnormal. So went in and did the TACE. You can see those vessels are no longer there. Here's the follow-up CT. Same thing with contrast. no longer enhancing. This is dead tumor. So it's been treated with the chemo. And then just like we were talking about radiofrequency ablation with the lung, they also use it frequently in the liver as well. So basically what they do, like we talked about with the lung, is they heat the tumor up to a temperature to kill the tumor cells. This is really a good treatment option for patients with early hepatocellular carcinoma who are not candidates for surgical resection. Again, just like what we were seeing on those images, it uses the body's blood supply and those abnormal vessels to heat up the area. So ideally, this should be for patients with tumors less than 3 centimeters. So if it's a larger tumor, it wouldn't work as well. This is an outpatient procedure, usually just a little bit of moderate sedation. You go home right afterwards, really little side effects. It's really good local control for early stage HCC. And now we're using it more also for patients with metastases. So say it's a breast cancer patient with a single mass in the liver, it would be a way to treat that single metastasis there. And studies have shown the survival with early HCC is similar to that achieved by operative resection. And liver surgery is no joke. It's this major surgery, so if you can avoid it and do it this way, it's a great option. This is a picture from the radiofrequency. So just like the lung, same thing. So you guys are going to be experts at reading these now. So aorta, it's a contrast study. You can see the mass there is enhancing. Here's with the probes going through the skin. Here are the ribs going through the ribs, here treating it. This is afterwards, and this is again what we want to see. It does look larger, but this is all dead tumor in the tissue right around it. And lastly, with liver, we also do radioembolization. Same concept, but using radioactive material to kill the tumor as well. This is tolerated, they say, somewhat better than the chemo, but same thing. Shooting the radiation into that part of the liver to kill the tumor. This just kind of goes into it, but basically the same as we were talking about with the other ones. This is just an example of a patient with multiple metastases. So this is a good option for someone that has multiple masses to be treated at once. So you can see here was the multiple, all these dark spots. These are the tumor. This is afterwards, and you can see some of them you don't really see anymore, and some of them are a lot smaller. So very good response to it's called Y90. Last slide, renal cancer is also amenable to RFA. Just wanted to touch on that. So just like what we were seeing in the liver and the lung. And then another common procedure with renal cancer now is cryoablation, which rather than heating it up, you freeze it. And renal cancer responds really well to that. Good candidates for this are patients with only one kidney, patients who cannot undergo surgery, again, small tumors, patients with bilateral renal tumors, and patients that had recurrent renal cell cancer after resection. So just another option. And that's it. I hope I didn't bore you too much, but it's kind of some of the screening and then the treatment that we can do in the radiology department. I told you we weren't that scintillating, but that's what we got. Yeah?
Is the bone scan the same as bone density?
No. No.
Question.
Is a bone scan the same as a DEXA scan, which is a bone scan? Totally different study. No radioactive material used for the DEXA scan. That is just looking at the density. So it's looking to see if the bone is strong or not. It does use X-ray, but none of that radioactive material. So you wouldn't be able to pick up tumor on a DEXA scan. Yes.
The 3D mammography is relatively new into St. Jude for the breast exam. You already have a short time, you already discovered the early detection of some of the cases which normally cannot detect in the 2D mammography. Would you continue collecting the statistics to show people that the 3D is really advantage over the 2D, especially for high density mass?
Yeah, so we are, so are we going to continue to look at the 3D benefit at St. Jude as compared to the 2D? And the answer is definitely yes. We're not conducting like an independent research study because our volume compared to the studies that have already been done is small relatively. But we are keeping a log of all those cases just so that we, can keep track, have that evidence to show what a benefit it is to our population. So any of those cases we're putting into a special database just for our own keeping to know. Yeah.
Will eventually all the mammographies be done with the 3D?
That's a good question. Will all mammograms be done by 3D? Probably not. For some reasons, patients with fatty breasts don't benefit as much, and it's purely out of a volume. The 3D mammograms take significantly longer to read, and they take a little bit longer to get. So just the process of reading all of them and keeping up with the volume at most breast cancer centers is difficult. So generally speaking, patients are a little bit triaged into who should be getting the 3D. I think at St. Jude we'll get there eventually and have to figure out what the best way to do that is. I think the goal right now is that everyone that comes through the breast center at St. Jude with the Tomo units will all get 3D at the breast center, but we do have the other outside clinics too. One question we get a lot is, well, I said breast MRI is the most sensitive study for looking at the breast. So do I have to get a mammogram if I'm getting a breast MRI? If the MRI is the most sensitive? And I actually was involved in a study answering this question at USC. And the problem is that MRI, the one cancer they will miss is DCIS, which is not an invasive cancer. It's a pre-invasive cancer that most of the time presents as really tiny calcifications on a mammogram, and MRI will miss those sometimes. Not all the time, but it does miss those cases. So you really have to do both in conjunction. Besides the fact that MRI as alone as screening will never replace mammogram just because it's way too many false positives. So there's way too many things that light up on a breast MRI that are of no importance, but then end up having to be worked up. So mammogram is here to stay. It's not going to get replaced by anything else. Yeah?
I think they should put the age from 40 to 30, because I was 36 when I had my breast cancer. So, there were no mammograms.
Yeah, so
I should do it earlier.
should we do mammograms earlier than 40 is the question. So routinely we don't do screening mammograms between the ages of 30 and 40. That being said, I would say in the last few months I've had probably 5 patients in their 30s with really bad breast cancer. So should we screen 30 to 40 with mammogram? It's not a bad question, and I think it's something that's been looked at. It's just been shown that 40 is really that brink where breast cancer increases to justify, and this isn't my opinion, but the cost of doing the mammograms. So that's why there's a lot of research into calculating patients' risk. So I don't know if you had a family history, but yeah, the patients that I've had recently don't, so they wouldn't even fall into that category either. But it's really, it's not common for 30-year-olds to have breast cancer, so the government and insurance don't think it's worth doing until 40.
Could you discuss the genetic counseling to patients who have had breast cancer in their family?
Yeah, so I actually was just talking to Rebecca, the genetic counselor at St. Jude, because I think that's something really important, that a lot of patients with either a personal history, family history of breast cancer, we're losing them and not getting genetic counseling. So I think it's important for everyone to be aware. And generally speaking, you should see a genetic counselor if anyone in the family was less than 45. So first degree or second degree relatives less than 45 with breast cancer. And then, or 2 first degree relatives less than 55. But generally speaking, if I see any patient with a first degree relative that had premenopausal breast cancer, I make the recommendation that they should probably see a genetic counselor. And then also between 30 and 40, you should also be getting now annual breast exam with your doctor. Though the government now says that we shouldn't, but the American Cancer Society, other societies still say that you should have annual breast exam.
You mentioned the stages of breast cancer. Could you define that, the various stages?
Sure, yeah, so it's based on mainly size. So, well, stage 0 is any cancer that's not invasive, so it's confined to the duct, so it hasn't developed a mass. And that's why we do screening mammogram. That's what we want to find. That's our goal. Stage 1 is a small cancer, so less than 2 centimeters. And then 3 and 4 is 2 to 5 centimeters is the range. And then depending on if there's any metastasis, there's many categories to go into, but that's generally. So our goal is always to find stage 0 and stage 1. Though I'll tell you, right before I came in, I was running late because a patient had had a mammogram in 10 years and had almost the whole upper outer quadrant of her breast was abnormal and tumor. So I hate seeing those cases. Those are the worst because you know it was preventable if they could have come in earlier and got it done. And I think with the older population too, it's important to still get the breast exam and still talk to your doctor about getting mammograms. And I don't think it ever hurts to have all the information. If you find something and you decide it's not right, it's not the right time for you to start chemotherapy or have surgery, that's your decision. But at least then that's your decision, because some of these cancers can be treated with hormonal therapy and other treatments that are really well tolerated. So I don't think there should ever be like an age limit on when you stop getting them done.
Is there a link between smoking and breast cancer?
There is. So smoking, being overweight, those can both be contribute to breast cancer risk. Yeah, so and all the healthy lifestyle modification. Yeah, so lose weight, stop smoking, decreases your breast cancer risk.
Okay. Interestingly, at St. Jude, they have a weekly breast cancer conference. The attendees at this conference are the radiologists, the radiation oncologists, the surgeons, the cancer specialists, the oncologist, and the primary care doctors. They're all there, and they discuss every case of breast cancer. Is that right?
Every case.
And it's a great conference. And I think, especially now with this 3D mammography there, again, St. Jude is sort of on the cutting edge of what's going on with not only the diagnosis, but the treatment of these various kinds of tumors. So it's, want to thank you. That was a great, comprehensive presentation, and I hope we all learned from it. I did.
Thank you for having me. This is great.